You know that feeling, right? That sudden knot in your stomach, maybe, or that pounding in your head that just won't quit. Pain. It's our body's alarm system.
Definitely. But figuring out why that alarm's ringing, well, that could be a real medical detective story sometime.
Exactly. How do doctors actually figure it out when symptoms could mean so many different things? It's complex stuff.
It absolutely is. It's detective work, really. Needs a solid grasp of anatomy, physiology, and knowing which tools to use to see what's going on inside.
And that's precisely the journey we're taking today. We've got this fascinating source material, really diving deep into two areas where that detective work is just critical: acute abdominal pain and headache.
Two incredibly common reasons people end up needing medical help, right?
For sure. And as these sources make really clear, the causes can range from, something quite simple to stuff that's genuinely life-threatening.
And navigating that range takes real precision. The sources kind of lay out a roadmap for how professionals tackle these challenges, specific tests, findings, the whole diagnostic strategy.
So our mission in this deep dive using these texts is to go really deep. We want to cover basically everything in here, aiming for that level of detail that, professionals grapple with every day.
Trying to get you that kind of insider's grasp on the logic, the potential pitfalls, the patterns they're trained to look for.
Exactly. Extracting those critical insights, the surprising details that differentiate one thing from another. Okay, let's unpack this detective story, starting with the abdomen, acute abdominal pain.
All right, that sudden bad belly pain sends a lot of people rushing for help, and understandably so. But figuring out the why isn't always obvious right off the bat.
It's super common, but the initial look can point in a dozen directions, can't it?
Oh, absolutely.
Yeah.
And the sources walk us through the first steps, but interestingly, they immediately flag some important limitations or caveats.
Yeah, right away they mention serum amylase levels. Now, I think most people connect high amylase with pancreatitis, right? Inflammation of the pancreas.
That's the common association, yes. But the sources are quick to point out amylase can be elevated for lots of other reasons too, many other things.
Like what, for instance?
Well, things like a perforated ulcer or a strangulating intestinal obstruction where the blood supply gets cut off, or even acute cholecystitis, which is gallbladder inflammation. Those can all push amylase up.
So a high amylase level isn't a slam dunk for pancreatitis then?
Exactly. And the crucial takeaway the source explicitly states is, elevated serum amylase does not definitively tell you if surgery is needed or not. It's just one piece of the puzzle, not the final word on intervention.
That's a great example, isn't it? How one test isn't the whole story. So what about imaging? Like plain x-rays of the abdomen, are those the go-to?
Actually, the sources say plain radiographs, the flat ones, upright ones, side ones, they have limited utility for acute abdominal pain when the cause isn't immediately clear.
Limited utility, so maybe not even needed sometimes.
Potentially, yes. The sources suggest they might not even be necessary if the clinical signs are already pointing strongly towards something specific like, say, acute appendicitis or maybe a strangulated external hernia.
Okay, so if plain x-rays aren't always the answer, where do doctors usually turn for imaging when things are still murky?
The strong preference highlighted in the sources is for low-dose computed tomography, CT scanning. It's preferred over plain x-rays for evaluating non-traumatic acute abdominal pain when it's not yet clear if surgery or some other intervention is needed.
Because CT gives a much better view.
A much more detailed cross-sectional view, yes. It lets you see structures much more clearly.
Okay. What about contrast studies, using things like barium? Do those come into play?
Upper GI contrast studies using either barium or a water-soluble contrast are described as very rarely appropriate in this acute setting. They might occasionally show a partial intestinal obstruction that other methods missed, but they're not a routine first step.
And there's a big warning about barium if you suspect a problem lower down in the colon.
Absolutely critical point. If there's any suspicion of a colonic obstruction, giving barium sulfate by mouth is a definite no-no, must be avoided.
Why is that?
If there happened to be a perforation, the barium leaking out could cause major complications like severe inflammation. However, if you suspect a colon obstruction without a perforation, then a contrast enema introducing contrast from below might actually be diagnostic. Different approach, different risks.
Got it. It sounds like the whole diagnostic approach for the abdomen has changed quite a bit over time. The sources mention something called peritoneal lavage.
Yes, peritoneal lavage. That involved washing out the abdominal cavity and analyzing the fluid. In the absence of trauma, though, it's been largely replaced.
Replaced by what?
Mostly by CT scanning, which gives such detailed images, and also by laparoscopy, which allows direct visualization. These newer methods are either less invasive or provide much more specific information for diagnosis.
Speaking of less invasive, ultrasound or ultrasonography still plays a role, though, right? It hasn't been completely replaced.
Oh, definitely not. Ultrasound is still very useful for specific things. Great for looking at an enlarged gallbladder or pancreas, confirming gallstones, or evaluating gynecological issues like an enlarged ovary or a suspected tubal pregnancy. It excels with fluid-filled structures or solid organs.
And laparoscopy, putting a camera in, sounds like it takes things a step further, maybe even towards treatment.
That's a huge advantage the sources highlight. Laparoscopy is especially helpful for diagnosing conditions in the pelvis, things like ovarian cysts, tubal pregnancies, infections like salpingitis, or even acute appendicitis if it's hiding down there.
And the big plus is,
The big plus is that if they find the cause laparoscopically, they can often fix it surgically right then and there during the same procedure. It's diagnosis and potential treatment rolled into one. Very efficient.
makes sense. What about HID scans? Where do they fit?
HID scans. That's radioisotopic hepatobiliary immunodiacetic acid scans. They look specifically at the gallbladder and bile ducts. They're useful for differentiating acute cholecystitis or biliary colic from acute pancreatitis when symptoms overlap. Helps pinpoint if the problem is gallbladder or pancreas.
And going back to CT scans, the preferred imaging initially, what specific signs are radiologists looking for on those?
CT is really good at showing things like an enlarged pancreas or maybe a ruptured spleen. If they suspect infection or inflammation in the bowel, like appendicitis or diverticulitis, CT can show a thickened bowel wall.
Anything else?
Yes, a really characteristic sign is streaking in the fat that surrounds the colon, or appendix, the mesocolon or rhizoappendix. Seeing that streaking is a strong visual clue for diverticulitis or appendicitis. Radiologists are trained to spot these specific patterns.
But even with all these advanced tools, the sources seem pretty realistic. They admit that sometimes you just can't get a definitive diagnosis right away.
That's such a critical point about real-world medicine. Sometimes the decision to operate might still be based only on the clinical picture, the patient's story, the exam findings, the doctor's judgment, even without a perfectly clear diagnostic image.
So what happens if it's questionable? You don't operate, but you're not sure what's wrong?
If the situation is less certain, the recommended approach is what they call watchful waiting, with repeated questioning and examination. Basically, careful observation over time.
Letting the situation evolve a bit.
Exactly. This often allows symptoms or signs to become clearer, pointing towards the right diagnosis and the right course of action. Observation itself becomes part of the diagnostic strategy.
It's not always instant answers then, which makes sense given how complex the body is.
Precisely. Sometimes you have to wait for the body to reveal its secrets, and careful, repeated observation is a crucial tool in the clinician's kit.
Okay, let's completely switch gears now. We're moving from the abdomen up to the head, because headache is another area where this diagnostic detective work is absolutely essential.
And headache is just incredibly common, isn't it? The sources point out it's one of the most frequent reasons people seek medical attention. And here's a staggering fact. Headache causes more disability worldwide than any other single neurologic problem.
Wow, more than any other neurologic issue. That really puts it into perspective. It's not just a minor annoyance for a huge number of people.
Not at all. And the sources stress that proper diagnosis and management really hinge on a careful clinical approach. But, and this is key, it has to be backed up by a deep understanding of the actual anatomy, the physiology, and the pharmacology of the nervous system pathways involved in head pain.
And getting a handle on all the different types of headache requires a clear classification system, I imagine.
It does. The standard is the International Headache Society system. It broadly divides headaches into primary and secondary types.
Primary means the headache is the problem itself.
Exactly. The headache and its features are the disorder. The sources list the big ones. Tension-type headache is the most common, around 69% of presentations, apparently. Then migraine at 16%. Less common are things like idiopathic stabbing headache, 2%, exertional headache, 1%, and the very severe but rare cluster headache, only about 0.1%. These primary types are often the ones causing significant disability.
Okay, and secondary headaches are symptoms of something else.
Correct. They're caused by some other underlying exogenous disorder. The sources give examples like systemic infection. I think the headache you get with the flu, that's actually a very common cause, accounting for maybe 63% of secondary headaches in some studies.
What else falls under secondary?
Head injury, about 4%. Vascular disorders like stroke, 1%. And then the really critical ones to not miss, even though they're less common. Subarachnoid hemorrhage, less than 1%. Or a brain tumor, around 0.1%.
So mild secondary headaches are common, but the really dangerous ones, while rare, need careful consideration.
Absolutely. Vigilance is key for those life-threatening ones.
Now, this is where, for me, it gets really fascinating. If you want to understand headache, like the actual anatomy and physiology, where does the pain come from inside the head? It's not as simple as my brain hurts, is it?
Not at all. That's a key point the sources really emphasize. Pain usually comes from stimulating specific pain receptors, nociceptors, often due to injury or inflammation. But pain can also happen if the pain pathways themselves are damaged or just firing inappropriately. Headache can be either.
And maybe surprisingly, not everything inside the skull can actually feel pain.
That's right. There are specific pain-sensitive structures. The sources list the scalp, the large arteries supplying the brain's coverings, the meningeal arteries, the big venous channels draining the brain, the dural sinuses, the tough membrane between the brain hemispheres called the falx cerebri, and the initial parts of the large arteries right on the surface of the brain, those are pain-sensitive.
And the parts that aren't pain-sensitive, this is counterintuitive.
Yeah, it is. Significantly, much of the brain tissue itself, the brain parenchyma, cannot produce pain. Also, the lining of the fluid-filled ventricles, the ependyma, the structures that make cerebrospinal fluid, the choroid plexus, and the smaller veins on the brain surface, pile veins, those are generally not sensitive to pain.
So a lot of headache pain is actually coming from the brain's coverings, or the blood vessels, or nearby structures, not the brain cells themselves. That really changes how you think about it.
It completely reframes it, and the sources directly connect this anatomy to the key structures involved in primary headaches, like migraine. They highlight the role of those large intracranial vessels and the dura mater, which are pain-sensitive, and how they're innervated by the trigeminal nerve.
Ah, the trigeminal nerve. That seems central to head pain.
It's absolutely central. It's the main nerve for sensation in the face and large parts of the head. Pain signals from those sensitive structures travel along the trigeminal nerve. The sources specifically mention a part called the caudal trigeminal nucleus.
Okay, what's significant about that nucleus?
It's significant because it extends down from the brainstem into the upper part of the spinal cord in the neck. And down there, it receives input not just from the trigeminal nerve, but also from the first and second cervical nerve roots, C1 and C2, coming from the neck.
So signals from the head and the upper neck converge in this one area.
Exactly. This convergence point is called the trigeminocervical complex. It's crucial because it explains why sometimes problems originating in the upper neck can be felt as headache and vice versa. Referred pain.
That makes so much sense. It's like a shared relay station. And from there, the signals go up to the brain.
Right. They ascend to higher pain processing regions like the ventroposteromedial thalamus and then the cortex, where you actually perceive the pain. And there are also important pain modulatory systems originating in places like the hypothalamus and brainstem that can influence the signal traffic, either dampening it or amplifying it. And they also control those associated symptoms like nausea or light sensitivity.
Now, let's tackle a major misconception that the sources really seem keen to correct. It's about those other symptoms you sometimes get with headaches, like watery eyes, stuffy nose, maybe a droopy eyelid.
Yes, the cranial autonomic symptoms. Things like lacrimation, tearing, conjunctival injection, red eye, nasal congestion, rhinorrhea, runny nose, maybe some swelling around the eye, a feeling of fullness in the ear, or ptosis, the droopy eyelid.
Where do you see those most prominently?
They are really striking features in a group of headaches called the trigeminal autonomic cephalalgias, or TACs, that includes things like cluster headache and paroxysmal hemicrania. But you can see some of these symptoms in migraine too.
And the common mistake is thinking these symptoms mean the pain must be coming from, say, inflamed sinuses or maybe swollen blood vessels.
That's exactly the common but incorrect interpretation the sources warn against. They clarify that these autonomic symptoms actually reflect activation of cranial parasympathetic nervous system pathways. And what's more, functional imaging studies have shown that the vascular changes like blood vessel dilation that are sometimes seen during migraine or cluster attacks are also driven by the activation of these same autonomic systems.
Ah, so the autonomic system firing off is the driver, and the runny nose or the blood vessel changes are the result, not the underlying cause of the headache itself.
That is the critical distinction the sources make. These are described as secondary, not causative events in the whole headache process. But because these symptoms can mimic sinus problems, they frequently lead to misdiagnosis and people getting treated for sinus headaches when that's not really the root cause.
So what's the really big takeaway message here? The core understanding the source's push for professionals.
They state it pretty unequivocally. Migraine and other primary headache types are not vascular headaches. They don't reliably show consistent vascular changes, and treatments targeting blood vessels don't necessarily predict whether the headache will get better. The fundamental understanding, strongly emphasized, is that migraine is a brain disorder.
A brain disorder, not a blood vessel disorder primarily.
Exactly. Its origins lie in abnormal activity within the brain's pain pathways, the trigeminocervical complex, and those modulatory systems we talked about. That reframes the whole approach.
That completely changes how you think about migraine, doesn't it? It's a complex neurological event. Understanding that is crucial for effective treatment.
Absolutely. It guides everything from diagnosis to choosing the right therapies.
Okay, let's shift to a scenario that immediately raises the stakes. Someone presenting with a new, severe headache. This feels different from someone who gets predictable migraines, right?
Very different. A new severe headache carries a significantly higher chance of being caused by a serious, potentially dangerous underlying condition compared to a long-standing recurrent headache pattern. Prompt evaluation is absolutely critical in this situation.
What are the urgent, serious things they need to rule out immediately?
The sources list several immediate concerns. Meningitis, that's infection of the brain's coverings. Subarachnoid hemorrhage, SAH, bleeding around the brain. Epidural or subdural hematoma, bleeding under the skull, often from trauma. Glaucoma, a sudden rise in eye pressure. A brain tumor, or even a severe bacterial sinus infection called purulent sinusitis.
And the sources helpfully provide a list of worrisome symptoms, basically, red flags that demand quick investigation. Let's run through those because they seem really important.
These are the signs that should make any clinician pause and think, okay, I need to dig deeper and fast. They include a really sudden onset headache, especially one hitting peak intensity within seconds or minutes, sometimes called a thunderclap headache.
What else?
The very first severe headache a person has ever experienced in their life, or simply the patient describing it as the worst headache ever. Also, vomiting that actually starts before the headache pain begins, rather than just coming along with it.
Any patterns over time?
Yes, a headache that's been gradually but noticeably worsening over days or weeks, or pain that's triggered or made significantly worse by things that increase pressure inside the head, like bending over, lifting heavy objects, or coughing hard.
And symptoms related to sleep or other signs?
A headache that disturbs sleep or is present immediately upon waking up. Also concerning, if the patient has a known systemic illness, like cancer or an immune deficiency. If the headache starts for the first time after age 55. If there's a fever or other unexplained systemic signs along with the headache.
And findings on exam.
Any abnormality found during the neurologic examination is a major red flag, and also pain associated with localized tenderness, for example, tenderness when pressing over the temporal artery in the temple area.
That's a pretty comprehensive checklist. So if any of those red flags pop up, the diagnostic process speeds up significantly. What does that evaluation typically involve?
The essential first step, always, is a careful neurologic examination. That gives vital clues about whether the brain or nervous system itself is affected. If that exam is abnormal, or if the history strongly suggests a recent onset severe headache, then brain imaging is definitely recommended.
Is it usually CT or MRI first? Are they equally good in this situation?
For this specific urgent scenario, new severe headache, maybe with red flags or an abnormal exam, the sources indicate that CT and MRI methods seem to be about equally sensitive for picking up significant intracranial problems. CT is often quicker and more readily available in emergency settings.
But even a normal brain scan might not be the end of the story. Sometimes a lumbar puncture, a spinal tap is needed.
Exactly. An LP is sometimes required to definitively confirm or rule out certain diagnoses, especially meningitis or subarachnoid hemorrhage, unless you can confidently establish a benign cause through other means.
And it can be needed even if the CT is normal.
Critically, yes. The sources point out that even with a normal head CT, an LP might still be necessary. For instance, a very small subarachnoid bleed, especially one located low down near the base of the skull, below the foramen magnum, might be missed on CT but show up as blood in the spinal fluid.
Okay, so beyond the neuro exam and scans, what else might be part of the workup for an acute, severe headache?
Depending on the suspected cause, a broader physical exam could be important. That might include feeling the arteries in the head, like the temporal artery, checking the neck's range of motion, cervical spine, and possibly getting neck images, checking blood pressure, and doing urine tests for cardiovascular or kidney issues, and a thorough eye exam.
What about the eye exam?
That includes looking at the back of the eye with an ophthalmoscope, fundoscopy, checking the pressure inside the eye, intraocular pressure, and assessing vision, refraction.
The sources also touch on the patient's psychological state, like depression or anxiety. How does that fit in?
There's definitely a known link, a comorbidity, between chronic pain, including headache, and mood disorders like depression and anxiety. But the source clarifies that assessing for these is mainly to identify this coexisting condition, not necessarily to assume it's the sole cause of a severe headache, especially a new one.
So treating the mood might help the headache, but the mood isn't necessarily the trigger.
Often, yes. It's interesting, though, that some antidepressants are actually effective as preventative treatments for certain types of headache, like migraine, which hints at complex shared biological pathways.
The sources also mention something interesting, how pain from somewhere else can actually trigger a known headache pattern.
Yes, they note that an underlying headache disorder, particularly a migraine syndrome that might have been dormant or quiet, can sometimes be reawakened or activated by pain coming from another source.
Like after dental work.
Exactly. Or maybe following ear surgery, or from some other kind of inflamed tissue or trauma nearby. The key point here is that trying to treat just the headache itself in that situation probably won't work very well until you address the primary problem, the source of that activating pain signal.
You have to fix the initial trigger first. That makes sense. It's also somewhat reassuring that the sources reiterate that brain tumors are actually a rare cause of headache, especially severe headache.
Yes, that's an important perspective. The vast majority of people who show up with even a severe headache will ultimately turn out to have a benign cause. But that vigilance for the rare but serious possibilities is exactly why those red flags in the thorough evaluation process are so incredibly important. You have to systematically rule out the dangerous stuff first.
Let's dig a bit deeper now into some of those specific secondary headache causes we mentioned earlier. The sources give details on their presentation and how they're diagnosed. The main principle seems to be focus on diagnosing and treating the underlying condition first.
Right. Starting with meningitis, the classic picture is an acute severe headache plus a stiff neck and fever. And the sources are clear. If you suspect meningitis, a lumbar puncture is mandatory.
And you mentioned earlier it can sometimes mimic migraine. That sounds like a potential pitfall.
It definitely is. Symptoms like a pounding headache, sensitivity to light, photophobia, nausea, vomiting those are common in meningitis, but also hallmarks of migraine, likely because similar pain pathways get activated. One potential clue mentioned in the sources is that pain with eye movement is often strikingly worse in meningitis.
Okay. How about intracranial hemorrhage, like the subarachnoid hemorrhage, SAH you mentioned?
This is the classic thunderclap headache scenario.
Yeah.
The typical description, according to the sources, is an acute, incredibly severe headache reaching maximum intensity in less than 5 minutes, lasting more than 5 minutes, often with a stiff neck, but usually without a fever.
What causes it, typically?
A ruptured brain aneurysm is a common cause, but bleeding from an arteriovenous malformation, AVM, or even bleeding directly into the brain tissue, intraparenchymal hemorrhage, can also present mainly as headache.
And again, imaging isn't always 100% definitive for SAH.
Correct. As we discussed, rarely a head CT can look normal, especially if the bleed is small or in a tricky location near the base of the skull. So if clinical suspicion remains high even after a negative CT, a lumbar puncture might still be needed to look for blood in the CSF and definitively diagnose or rule out SAH.
What about brain tumors? We know they're rare causes of severe headache, but do they have a typical headache pattern when they do cause pain?
The headache from a brain tumor is usually pretty nondescript, actually. Often described as intermittent, a deep, dull ache, usually moderate in intensity. It might get worse with exertion or changing position. It might come with nausea or vomiting. But the sources emphasize that this symptom pattern is much more commonly seen with migraine than with a tumor.
Are there any more specific clues that might point towards a tumor if headache is present?
Yes, a couple of things. Vomiting that consistently precedes the onset of the headache by weeks is highlighted as highly characteristic, especially for tumors in the posterior fossa, the back part of the skull.
Interesting. Any others?
A history of missed periods, amenorrhea, or unexpected milk production, galactorrhea, could suggest a pituitary tumor. A brand new headache in someone already known to have cancer elsewhere raises suspicion for brain metastases or cancerous meningitis. And a headache that comes on abruptly after bending, lifting, or coughing could suggest a posterior fossa mass, a Chiari malformation, or possibly low CSF volume headache.
Okay, let's talk about temporal arteritis or giant cell arteritis. You mentioned this earlier. It sounds critical not to miss, especially in older adults, because of the blindness risk.
It is absolutely critical. Temporal arteritis is an inflammatory condition affecting arteries, typically seen in people over 50, average age around 70, and it's more common in women. The major risk, as you said, is blindness. About half of untreated patients can lose vision, often rapidly and in both eyes, due to inflammation affecting the ophthalmic artery. It's a leading cause of sudden bilateral blindness in older adults.
Which means quick diagnosis and treatment are vital.
Paramount. Prompt recognition and starting high-dose glucocorticoids, like prednisone, immediately is crucial to prevent vision loss.
What are the typical symptoms besides the headache itself?
Many patients also have something called polymyalgia rheumatica, that's muscle aches and stiffness, particularly in the shoulders and hips. The headache itself can be one-sided or both, often felt in the temples, about 50% of cases, but really it can occur anywhere on the head.
How does the headache feel?
Onset is usually gradual, over hours, though sometimes it's described as explosive. The quality is often described as dull and boring, but frequently with superimposed sharp episodic stabbing pains. Interestingly, some patients describe the pain as feeling superficial, like it's external to the skull, which can be different from the deeper pain of migraine.
And what might you find on physical examination?
Marked scalp tenderness is very common. Patients might say it hurts to brush their hair or even lay their head on a pillow. The headache often worsens at night and can be aggravated by cold. You might see redness, tender nodules, or red streaking over the temporal arteries themselves, and they may be tender to palpation.
How is it diagnosed, especially given the urgency? You mentioned blood tests and biopsy.
An ESR, or erythrocyte sedimentation rate, which is a blood marker for inflammation, is often elevated. However, and this is a really important caution from the sources, a normal ESR does not rule out temporal arteritis. If clinical suspicion is high based on the symptoms and exam, a temporal artery biopsy is recommended to confirm inflammation in the artery wall.
But you don't wait for the biopsy result to treat.
Absolutely not if suspicion is high. Because the risk of blindness is so significant, immediate treatment with high-dose prednisone, like 80 mg daily, should be started for several weeks, typically 4 to 6 weeks initially, without waiting for the biopsy results. Treat first, confirm later.
That makes sense. Preserve vision first, but there's a caveat.
That's an important one. Migraine is actually much more common than temporal arteritis, even in the elderly. And people with migraine often feel better when they take prednisone. So just seeing improvement on prednisone doesn't automatically confirm temporal arteritis in an older person with headache. You have to interpret that response carefully in the context of all the other clinical features.
Okay, one last specific secondary cause mentioned is glaucoma.
Yes, acute angle closure glaucoma. This can present as an absolutely prostrating, severe headache, often with nausea and vomiting. The key differentiator, though, is that the headache typically starts with, or is accompanied by, severe eye pain. And on exam, the affected eye usually looks red, and the pupil is often fixed in a mid-dilated position. That combination, severe eye pain plus the red eye and fixed pupil, is a major clue.
We've covered a lot on secondary headaches, which is vital because they can be dangerous. But let's quickly loop back to the primary headache disorders.
Right. The sources cover those in great detail elsewhere, but it's worth reiterating. Primary headaches like migraine, tension-type headache, and the TACS cluster, etc., are the disorder themselves. Understanding their classification and the pathophysiology we discussed, the trigeminocervical complex, the autonomic involvement is really foundational, as these conditions cause immense disability.
Now let's tackle a particularly tough area for both patients and doctors. Chronic daily or near-daily headache, often abbreviated as CDH. That's defined as headache on 15 or more days per month.
CDH is a really significant problem, affecting something like 4% of adults. And a crucial point the sources make right away is that CDH is not a single diagnosis in itself. It's more of a description that covers a whole range of different underlying headache syndromes, which can be either primary or secondary.
So someone headachy almost every day could have chronic migraine, but it might be something else entirely causing it.
Exactly. The sources list a whole spectrum. Primary CDH types include chronic migraine, chronic tension-type headache, hemicrania continua, chronic cluster headache, hypnic headache, a rare one waking people from sleep, and new daily persistent headache, which we need to discuss separately.
And secondary causes leading to daily headache.
Secondary causes of CDH include things like post-traumatic headache, headaches caused by medical treatments, iatrogenic, post-infectious headache, ongoing inflammation like giant cell arteritis or sarcoidosis, chronic infections of the central nervous system, headaches related to low or high CSF pressure, and a really important one, medication-overuse headache, MOH.
Wow, that's a complex list to untangle. How do the sources suggest approaching a patient who presents with CDH?
It's a systematic process. Step 1 is absolutely crucial. Diagnose and treat any identifiable secondary headache first. You have to rule out or manage things like MOH, CSF pressure issues, or inflammation before focusing just on a primary type, even if a primary type seems to be involved too.
Okay, so tackle secondary causes first. What if none are found or you're clearly dealing with a primary type as well?
Then step 2 is to accurately diagnose the specific primary headache type. Is it chronic migraine, chronic tension type, etc., because that guides therapy. Step 3 is then to initiate appropriate preventive treatments, aiming to break the cycle and reduce the frequency and severity of the headaches.
What kinds of preventative treatments are highlighted for CDH in the sources?
Tricyclic antidepressants like amitriptyline or nortriptyline are mentioned as being very useful, especially for CDH that arises from migraine or tension-type headache, or when a secondary issue has perhaps activated an underlying primary headache tendency.
How are they typically used?
Dosing usually starts low, maybe 10-25 milligrams daily, and is increased gradually, sometimes up to 1 milligram per kilogram of body weight. The sources even suggest timing the dose about 12 hours before the desired wake-up time to minimize morning drowsiness, which can be a side effect.
And specifically for chronic migraine, are there other preventives mentioned?
Yes, other options include anticonvulsants like topiramate and valproate, beta blockers like propranolol, an angiotensin receptor blocker called candesartan, flunarizine, which is noted as not available in the U.S., and very importantly, the newer therapies that target the CGRP pathway.
CGRP, what are those?
Those are the monoclonal antibodies directed against CGRP or its receptor, or the small molecule CGRP receptor antagonists called GANPANTs. These have become major players in migraine prevention, especially chronic migraine.
The sources also mention managing headaches that are really disabling or medically intractable, meaning they don't respond well to standard treatments.
Yes, this is obviously a very difficult situation for patients. What options are discussed for these really tough cases?
Well, the CGRP pathway drugs, the antibodies and GAPANs, are specifically noted as being effective and generally well-tolerated in chronic migraine, and they're now licensed and available. Beyond medications, there's also discussion of non-invasive neuromodulatory approaches.
Neuromodulation, what does that involve? These are devices used externally to influence brain activity. Examples given are single-pulse transcranial magnetic stimulation, STMS, and non-invasive vagal nerve stimulation, NVNS.
How are those thought to work?
They seem to modulate pain processing, perhaps in the thalamus, or affect brainstem mechanisms involved in generating or propagating headache attacks. Non-invasive vagal nerve stimulation, in particular, has shown success in tough-to-treat conditions like chronic cluster headache, chronic paroxysmal hemicrania, hemicrania continua, and potentially even rarer attacks like SENCT or Shunan.
Now, let's focus on one of the most critical and challenging aspects of CDH that the sources detail, medication-overuse headache, or MOH. You called it a vicious cycle earlier.
It truly is. The core problem is that overusing the very medications taken to stop acute headaches, the analgesics, triptans, opioids, etc., can paradoxically increase headache frequency, make preventive medications less effective, and induce this refractory state called MOH. The treatment becomes part of the problem.
The logical solution seems to be stopping the overused medication, but the sources suggest it's often not that simple.
It's definitely not simple. While stopping the offending analgesic often leads to a significant improvement in headache severity and frequency over time, the sources make a really important point. Many patients still have considerable headache after they stop the overused medication.
What does that residual headache usually represent?
That residual pain typically represents the underlying primary headache disorder, most commonly chronic migraine, which was there all along and was likely worsened or perpetuated by the medication overuse. The MOH was layered on top.
So how is MOH typically managed, especially on an outpatient basis?
The core strategy is, of course, reducing or eliminating the overused medications. Success rates vary, and it can be tough. Approaches mentioned include a gradual dose reduction, maybe 10% every week or two, or, if there are no contraindications, just stopping abruptly. Keeping a detailed medication diary beforehand is crucial to understand the scope of the overuse.
What about managing the pain during that withdrawal phase? That sounds like it could be rough.
It can be. The sources suggest that sometimes a small dose of a long-acting NSAID, like naproxen, say 500 milligrams twice a day, if tolerated, might help manage the residual pain during the tapering or withdrawal period. They specifically note that overuse problems seem less likely with scheduled use of longer-acting NSAIDs compared to frequent, as-needed use of shorter-acting ones.
When do you bring in preventive medications in this MOH scenario?
Preventives can be started either after a substantial reduction in the overused analgesic has been achieved, or sometimes concurrently with the withdrawal process. However, there's a very strong caution in the sources. Preventive medications may not work effectively as long as the patient continues to overuse acute medications, especially opioids.
So, ongoing analgesic overuse can actually block the effect of preventatives.
Yes, it's highlighted as perhaps the most common reason why otherwise appropriate preventive headache treatments fail to work. You have to address the overuse first, or at least simultaneously. Managing patient expectations is also key.
How so?
Patients need to be informed upfront that some degree of headache is almost inevitable during the initial withdrawal period. Knowing to expect that can help them persevere through it.
What about patients who struggle with outpatient withdrawal or have other complex medical issues?
For those individuals, maybe they failed outpatient attempts or have conditions like diabetes or epilepsy that complicate things. Hospitalization for detoxification might be necessary. In the hospital setting, the overused medications are usually withdrawn completely on day one, assuming it's safe to do so.
And how do they manage the anticipated withdrawal symptoms and pain in the hospital?
They use supportive measures like anemetics for nausea and IV fluids for hydration. If opioids were being overused, a medication like clonidine can help manage specific withdrawal symptoms. For acute, severe breakthrough pain during the day, IV aspirin, 1 gram, is mentioned as potentially useful, though noted as not approved in the U.S.
Right.
At night, intramuscular chlorpromazine might be used, ensuring the patient stays well hydrated.
And you mentioned IV DHE earlier, dehydroergotamine.
Yes, IV DHE is often a key part of inpatient MOH treatment protocols. It's typically started maybe 3 to 5 days into the admission once the effects of the withdrawn medications are waning. It's given regularly, usually every 8 hours, for a set course, often 5 consecutive days.
And the sources stress not stopping it early.
Critically, yes. It should not be stopped short just because the headache might temporarily improve. The goal of the full course is to try and induce a more sustained remission, to break the cycle and create a window where preventive medications can finally start to work effectively.
But DHE often causes nausea, right?
It frequently does.
Yeah.
So effective antiemetics are essential. The sources mention using serotonin 5-HT3 antagonists like ondansetron or granisteron, or the neurokinin antagonist aprepitant. Domperidone, given orally or as a suppository, though not available in the U.S., is also noted as effective. The advice is to avoid antiemetics that are heavily sedating or have lots of other side effects if possible.
That intensive inpatient approach really highlights how difficult and entrenched medication overuse headache can become. Okay, let's shift to another distinct headache syndrome discussed under the umbrella of CDH, new daily persistent headache, or NDPH.
Right, NDPH. It's described as a clinically distinct syndrome characterized by headache occurring on most or all days. It's particularly important because, as the sources categorize, it has several key secondary causes that must be considered, alongside primary forms.
What are those main categories?
The sources list primary NDPH, which can have migrainous features or be more featureless, like tension type, and then secondary causes, including subarachnoid hemorrhage, SAH, headache due to low CSF volume, headache due to raised CSF pressure, post-traumatic headache, and chronic meningitis.
What's the key feature that makes NDPH stand out clinically at the beginning?
The hallmark, the key diagnostic feature, is that the patient can usually recall, often quite clearly and vividly, the exact moment or specific day the headache started. It typically begins abruptly, though sometimes it can evolve over a maximum of about 3 days. But once it starts, this new persistent head pain does not remit. That clear memory of onset is characteristic.
Given those potential secondary causes, what's the absolute top priority when someone presents like this?
The very first priority is to distinguish between a primary NDPH and a secondary cause. And the sources explicitly state that subarachnoid hemorrhage, SAH, being the most serious cause of abrupt onset headache, must be excluded first, either by history or appropriate investigation like imaging and potentially LP.
Okay, let's look more closely at some of those specific secondary causes of NDPH, starting with low CSF volume headache. This one has a really characteristic symptom, doesn't it?
It absolutely does. The defining feature is its positional nature. The headache starts or gets significantly worse when the patient sits or stands up and dramatically improves or resolves when they lie down flat.
How does the pain typically feel?
Often described as a dull ache, maybe throbbing, frequently felt in the back of the head, occipital and frontal, so occipitofrontal.
And in chronic cases, how does it behave through the day?
In chronic low CSF volume headache, it's typically not present right upon waking, but gets progressively worse as the day goes on while the person is upright. Lying down brings relief within minutes, but the pain returns within minutes to an hour of getting back up.
What's the most common reason someone might develop a low CSF volume headache?
By far the most common cause is a cerebrospinal fluid, CSF leak, following a lumbar puncture or spinal tap. The source is, quote, an incidence of 10–30% after LP, usually starting within 48 hours, but sometimes delayed up to 12 days.
Are there other potential triggers?
Yes, other things that can sometimes lead to a CSF leak include epidural injections or any activity involving a really vigorous Valsalva maneuver. Think heavy lifting, severe straining, prolonged coughing fits, maybe forcefully clearing your ears on an airplane, or even multiple orgasms. Spontaneous CSF leaks can also happen without any clear trigger.
And you mentioned the positional aspect might fade over time.
Yes, the sources note that in chronic cases that clear postural nature might become less apparent over weeks or months, which can make the diagnosis trickier later on. It's also mentioned that the core issue seems to be low CSF volume, not necessarily just low pressure, as pressure readings can sometimes be normal despite a leak.
Anything else that might present similarly?
POTS, or postural orthostatic tachycardia syndrome, can also cause headaches that worsen upon standing, so that needs to be considered in the differential.
How do they typically investigate if they suspect a CSF leak is causing the NDPH?
If imaging is needed, the initial study of choice is usually an MRI of the brain with gadolinium contrast. The sources describe a finding that can be very characteristic. Striking diffuse meningeal enhancement. This means the membranes covering the brain light up brightly and diffusely after the contrast is injected. Sometimes this pattern alone strongly suggests the diagnosis in the right clinical setting.
Does the MRI show the leak itself?
Not usually the brain MRI. That shows the consequences of the leak, the meningeal enhancement, sometimes the brain sagging. To find the actual leak location, specialized spinal imaging is often needed, like spinal MRI with T2 weighting, looking for fluid collections, or sometimes more invasive tests like CT myelography or digital subtraction myelography. The sources mention that occasionally Chiari malformations are seen on the brain MRI in these patients, but surgery for the Chiari is not indicated and usually makes the headache worse.
Okay, so if low CSF volume headache is suspected or confirmed, what's the initial treatment approach?
Initial management is often conservative. Bed rest. If the pain persists, intravenous caffeine infusions, like 500 milligrams and 500 bilifel saline over 2 hours, can be remarkably effective. An ECG screen is recommended first. The sources suggest trying at least 2 caffeine infusions before doing lots more tests to find the leak, as it can sometimes resolve the issue.
Anything else non-invasive?
An abdominal binder, worn tightly, can sometimes help by increasing abdominal pressure, which might indirectly increase CSF pressure in the head. If a leak site is identified or strongly suspected, like after an LP, then an epidural blood patch is often curative. That involves injecting the patient's own blood into the epidural space near the leak to seal it. For intractable cases, oral theophylline is mentioned as an option, but it can take months to work.
Okay, let's flip to the opposite scenario. Raised CSF pressure headache, another secondary cause of NDPH.
Right, elevated intracranial pressure. Sometimes brain imaging reveals an obvious cause, like a tumor or hydrocephalus. But NDPH can also be the presenting symptom of idiopathic intracranial hypertension, IIH, which used to be called pseudotumor cerebri.
And IIH is associated with certain patient groups.
Yes, it's strongly associated with obesity, being female, and sometimes pregnancy. A really key point the sources make is that IIH can occur without any visual problems or visible swelling of the optic nerves at the back of the eye, papilledema, although classic IIH often includes papilledema.
What's the typical headache pattern like in IIH? How does it differ from low-pressure headache?
The headache is usually generalized, often present upon waking in the morning, and tends to improve as the day goes on. Crucially, it's typically worse with lying down recumbency, the opposite of low CSF volume headache. Patients also frequently report transient visual obscurations, brief episodes where vision dims or blacks out, especially when the headache is most severe.
Diagnosis is easier if there's papilledema, but you have to consider it even without.
Exactly. Even with normal appearing optic discs, IIH should be considered if the headache pattern fits. Formal visual field testing is still necessary. The sources also mention that partial blockages in the brain's venous sinuses can sometimes play a role, and persistently raised pressure, even without a mask, can sometimes trigger a chronic migraine syndrome.
Are there other common causes of morning headache?
Yes, besides IIH, obstructive sleep apnea or poorly controlled high blood pressure can also characteristically cause headache upon waking or during the night.
How is suspected raised CSF pressure evaluated?
Brain imaging is essential first, to rule out a mass or other structural cause. The sources recommend MRI, including an MR venogram to look at the venous sinuses as the most efficient initial study. If the imaging is clear and there are no contraindications, a lumbar puncture should be performed while the patient is symptomatic, specifically to measure the opening pressure.
What confirms the diagnosis?
An elevated opening pressure, the exact number can vary, but often 250 millimeter H2O in obese individuals, combined with improvement in the headache after removing 20-30 millimeter of CSF, is considered diagnostic, assuming no mass was seen and fundal changes aren't the main issue.
And the treatment for IIH?
Initial medical treatment is usually with acetazolamide, a medication that reduces CSF production, typically 250-500 milligrams twice daily. Headache may improve over weeks. If that's not effective, topiramate is often used next, as it also inhibits carbonic anhydrase, can promote weight loss, and stabilizes nerve membranes. For severely disabled patients who don't respond, more invasive options like ongoing ICP monitoring or surgical shunting to drain CSF might be considered, and weight loss is strongly encouraged for overweight patients.
Post-traumatic headache is another secondary cause of NDPH listed. How is trauma defined here?
Yes, a traumatic event can trigger a headache process that just doesn't quit, lasting months or years. The sources use trauma quite broadly. It obviously includes head injury, even mild concussion. But it can also be triggered by an infectious episode, like viral meningitis, or even just a significant flu-like illness or parasitic infection in some cases.
What other symptoms might go along with post-traumatic headache?
Patients often report associated symptoms like dizziness, vertigo, trouble concentrating, or memory problems. These symptoms, along with the headache, might resolve within weeks, but sometimes they persist for months or even years. Neurologic exam and standard brain imaging, CT/MRI, are usually normal, though imaging is important to rule out things like a chronic subdural hematoma, which can sometimes mimic this. This type of persistent headache can also follow specific events, like a carotid artery dissection, subarachnoid hemorrhage, or intracranial surgery. The underlying idea seems to be that some kind of traumatic insult involving the pain-sensitive meninges or nearby structures can, in susceptible individuals, trigger a persistent ongoing headache process.
The sources also mention other potential triggers for NDPH onset, like flu-like illnesses.
Yes, they note that in some patient series, maybe up to a third of people with NDPH report the headache starting right after some kind of transient, non-specific flu-like illness, maybe with fever, neck stiffness, slight sensitivity, feeling generally unwell. Often, investigations find no specific ongoing cause. There's no good evidence linking it to chronic viruses like Epstein-Barr. One important caveat: if an LP was done during that acute illness, you have to consider if the persistent headache might actually be an iatrogenic, low CSF volume headache triggered by the procedure.
So given that NDPH is this distinct syndrome but can have various underlying causes or just be primary, how is the headache itself treated when no secondary cause is found or after it's addressed?
Treatment for primary NDPH, or the residual headache after treating a secondary cause, is described as largely empirical, meaning based on experience and observation, and guided by the specific features or phenotype of the headache the patient has.
What medications are tried?
Therapies commonly used for other chronic primary headaches are often employed. Tricyclic antidepressants like amitriptyline are mentioned. Anticonvulsants like topiramate, valproate, maybe candesartan or gabapentin have reported benefits. In select refractory cases, the MAO inhibitor phenelzine might be considered. While it can be very difficult to treat, the sources suggest the headache often resolves spontaneously, usually within 3 to 5 years for many patients, but it can certainly be disabling in the interim.
Finally, the sources bring all this incredibly detailed information back into the context of everyday practice, discussing the role of primary care and the decision of when to refer a patient with headache to a specialist.
Yeah, this is really important. Where does most of this start? For the vast majority of patients, it's in the primary care setting, and the primary care physician has this incredibly challenging task: sorting out the very few potentially worrisome secondary headaches from the overwhelming majority of primary headaches, like migraine or tension type, or less dangerous secondary ones.
So, if someone comes in with a headache but has none of those red flag warning signs we discussed, what's the general approach in primary care?
Without immediate warning signs, the sources suggest a reasonable approach is to try and establish a diagnosis based on the clinical pattern and history, and then initiate appropriate treatment for the suspected type, like migraine. Investigation at this stage often focuses on ruling out those worrisome secondary causes, or perhaps just helping the patient gain confidence that nothing serious is being missed if a clear primary diagnosis isn't immediately obvious.
And follow-up is key.
Absolutely essential. The sources really emphasize the importance of scheduled follow-up to monitor progress. The rationale is that truly worrisome headaches generally will progress or develop new, concerning features over time, making them easier to identify later if they weren't clear initially. Continuous monitoring is vital.
It's also a striking piece of context that the sources note over 90% of patients who present to primary care specifically complaining of headache ultimately have migraine.
That statistic really underscores why being comfortable diagnosing and managing migraine is such a core skill in primary care. It's overwhelmingly the most common thing they'll see.
So when should a primary care physician consider referring a patient with headache to a neurologist or headache specialist, according to these sources?
Referral is typically indicated in a few key situations. First, if there's no clear diagnosis despite a reasonable initial evaluation. Second, if the patient seems to have a primary headache disorder other than the common ones like straightforward migraine or tension-type headache, for example, if they suspect attack or NDPH or something less common.
And the third situation.
Third, if the patient's headache is unresponsive to 2 or more standard appropriate therapies for their suspected headache type. If first and second line treatments haven't worked, specialist input is often needed. Of course, the threshold for referral also depends on the individual primary care doctor's own experience and comfort level with managing complex headaches, and naturally, on the local availability of specialist services.
That makes perfect sense. It's about recognizing the limits of primary care tools or expertise for certain complex cases and knowing when specialized knowledge is needed to dig deeper or manage refractory situations.
Precisely. It acknowledges the incredible complexity these headache disorders can present and the value specialist input can bring for the really challenging presentations.
Wow. We have certainly taken a deep dive into these sources today. We started by really dissecting the diagnostic puzzle of acute abdominal pain, looking at the utility but also the limits of tests like amylase, plain x-rays, CT, ultrasound, laparoscopy.
And understanding that sometimes just careful observation, that watchful waiting is the right initial strategy. Then we plunged into the really intricate world of headache.
We did. We classified primary versus secondary types, tried to understand the actual pain-sensitive structures and pathways inside the head, identified those crucial red flags for serious causes like bleeding or infection.
And went into detail on managing the tough stuff like chronic daily headache, that vicious cycle of medication-overuse headache, and the treatments involved, even inpatient protocols with DHE.
And we spent significant time unpacking that distinct syndrome, new daily persistent headache, understanding its abrupt onset, and exploring its key secondary causes, especially low and raised CSF pressure headaches, their unique positional features, imaging clues like meningeal enhancement, and specific treatments from caffeine and blood patches to acetazolamide.
Yeah, by really pulling apart these sources piece by piece, the aim was to give you, the listener, a truly in-depth understanding, a glimpse into the clinical reasoning, the sheer amount of specific detail that clinicians need to master when facing these common, yet potentially very complex situations.
Highlighting the subtle clues, the power, but also the limitations of different tests, and those fine nuances that help tell one diagnosis apart from another. It really is insight into the detective work.
Absolutely. Mastering these topics requires that level of detailed knowledge.
So what does this all mean for you? Maybe consider this. Pain is the body's most insistent messenger, isn't it? That knot in the gut, that pounding head, it's a signal demanding interpretation.
As we've seen, interpreting it accurately is crucial.
How do we all clinicians and informed individuals alike learn to listen properly, knowing that signal could stem from simple indigestion or stress, all the way to a brain bleed, a chronic inflammatory state, or a complex neurological disorder? Getting the details right, as these sources show, isn't just academic. It can make all the difference.
The detail really does matter in medicine.
So reflecting on everything we've unpacked today from these sources, what specific detail or maybe diagnostic challenge related to either abdominal pain or headache stands out most vividly to you now, something to really mull over?